Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. CAR T cells. What's the hype? What are these chimeric antigen receptor T cells, and where are they currently being used? To help us navigate this complex and promising field, we're joined by Dr. Max Konig, a rheumatologist and researcher who has been exploring chimeric antigen receptor T cell therapies to treat autoimmunity. Dr. Konig will explain how CAR T cell therapy works, how the engineered cells are made, administered, and given to patients. We'll delve into the risks and side effects of CAR T cell therapy and their management. We'll focus our discussions to the use of CAR T cell therapy in rheumatology, including highlighting recent successes and the areas that are currently being targeted for CAR T cell therapy. We'll also talk about rheumatic diseases that may be amenable to CAR T cell therapy, as well as those that may not benefit from CAR T cell therapy at all. Finally, we'll touch on the costs and ethical considerations of these very expensive therapies and what the future holds for CAR T in rheumatology. Dr. Max Konig is Assistant Professor of Medicine in the Division of Rheumatology and Director of the Cellular Therapy Program in the Department of Medicine at the Johns Hopkins School of Medicine. Without further ado, here's Dr. Max Konig. Max, welcome to the show.
Thanks so much for having me, John.
So, what's up with the hype about CAR T cells? I mean, we're seeing them all over the place, and they're starting to make their way into rheumatology. Can you tell us a little bit about, give us a primer about what CAR T cells are and where they are currently being used?
Yeah, it's such a fascinating 2 years, I would say, John. I realized when I started to think about these and how many confused looks I got from my colleagues. And now it's really the talk of town. So a lot can change in just a couple of years. So to your question, so when we talk about CAR T cells, we talk about chimeric antigen receptor T cells. So those are a subgroup of engineered, what I call immune effector cells. And these are therapies that have the potential to eliminate other cell types. Historically, these CAR T cells have been used to treat cancer cells, but they can target all kinds of other cells. They could target virus-infected cells to potentially treat viral infection, and they could treat autoimmune diseases by targeting autoreactive B cells and maybe in the future autoreactive T cells. To date, CAR T cells have been probably most successful in targeting malignant B cells and plasma cells in patients with lymphoma and multiple myeloma. And that is maybe due to their accessibility. Like you have these B cells existing in lymphoid niches and circulating rather than being in a very dense immunosuppressive environment of a solid tumor. And there are markers available that allow us to selectively target them. Think of like CD20 or CD19 or BCMA. All of these are surface markers of B cells that are not expressed on other tissues.
So basically what you're doing is you're engineering your body's own T cells to recognize and kill, I guess for cancer, these malignant cells, and you identify them because of the cell markers that they have. And I guess you target your T cells to identify those specific cell markers on the cell surfaces of cancers.
Yeah, that's correct. So maybe this is a good time to talk a little bit how they came to be, because it is somewhat of an artificial construct and people may not realize this. So if you think back a few decades, people always realize that T cells are potent killers. That's what they're naturally good at, right? That's how they evolved. And there were observations that killers and T cell killer cells are able to hinder tumor growth, eliminate tumors. But there has always been a fundamental limitation of T cells. If you think about them as something that could be moved into a therapeutic space. And that is that a T cell in its very natural state only recognizes things when they are presented in the context of something called human leukocyte antigens, or HLAs. So every of our cell has like these HLA molecules on the cell surface, and they sample basically parts and peptides that are within the cell and presented on the cell surface, so they're accessible to the T cells to see. The limitation here has really been that if you want to make a therapy, you would need to make therapies for different small groups of patients, because the HLA molecules are so variable that if you wanted to make effective T cell therapies for different people, you would need to account for that variability, because the T cell receptor not only recognizes the specific small peptide that's presented, but also recognizes it in the context of that molecule. So people were thinking very early on, how can we overcome that limitation? How can we make T cells that now can target something that is ubiquitous, that's on every target cell? So if you want to target a B cell and you think the B cell molecule on the cell surface called CD19 is the perfect target, it's not on other tissues. It's expressed selectively on B cells. If all your tumor cell have that marker, you could eradicate all the tumor cells in all patients in theory, right? But the limitation was, well, how do we overcome that selectivity of the natural T cell receptor? So luckily, there is a solution in nature for that. So our B cells and the antibodies that they secrete, they can bind antigen independent of these HLA molecules. So people very early thought, well, what if we can create a chimeric receptor that takes the best parts of the antibody system that recognizes something like CD19 independent of HLA, and we fuse that to the best parts of the T cell receptor that creates that signaling and that effective killing. And that started and really jump-started the whole field in the late 80s, where for the first time people were cloning now chimeric receptors, where they took the essential parts of an antibody. It's called the scFv. It's called a variable heavy and a variable light chain. These are the smallest parts of the antibody that are needed to still have the specificity. And they fused it to the constant domains of the T cell receptor. And those T cells, when they express these new chimeric receptors, so initially something derived from the original T cell receptor, were able to respond to the specific antigen that the antibody recognizes, and it led to activation of the T cell. And then over the next few years, maybe the next decade, there were multiple iterations of these receptors. And eventually we came to a single molecule protein design that is now called the CAR. And what the CAR essentially is it is a almost like Frankensteinian receptor, where you take the best pieces that are essential to create the best possible response. So they took the antibody binding domains of whatever antibody you would like to have as a specificity. So imagine we're often using antibodies that target B cells, that target CD19 or CD20. So you could take the essential pieces of that receptor and use that as the binding domain. And then you create a fusion protein with a couple of other things. One is an essential piece of the natural T cell receptor called CD3 zeta. It's inside the cell and it's actually what conducts the signal to activate the T cell. And then a couple of other domains that link it basically in the cell membrane. And the early designs were just that: a little bit of antibody binding domain, a hinge region, this transmembrane domain, and then the signaling domain in the inside of the cell, the CD3 zeta. And it became very clear quickly that even though they can kill and they can recognize antigen, these cells very quickly die. And they die through something called activation-induced cell death. So that is actually a mechanism that's important in all of us to prevent autoimmunity. You don't want to overactivate all your T cells. But here was really limiting, because even though they might kill a cell once, they basically didn't proliferate. They didn't expand in vivo. So they were essentially not able to fully control a tumor. Think of a B-cell lymphoma. And in 2003, a group in St. Jude solved that problem. And they integrated for the first time something called a co-stimulatory domain. 4-1BB, sometimes we use a different molecule called CD28. And when they integrated this into that CAR construct, which we now call first generation CAR, so it became a second generation CAR construct, which is the one that we still use in clinical practice today. Now, all of a sudden, not only was the specificity preserved, but these T cells proliferated in vivo and were able to completely control tumors, first in animals, and then subsequently shown in the work by at the University of Pennsylvania, at Sloan Kettering, were able to have these transformative results in patients with lymphomas, both children and adults. So that's where we are. We have these Frankensteinian constructs that are really specific, that can selectively recognize something in an HLA-independent fashion and activate the T cell as if they would naturally respond to an antigen.
That's actually the first time that I truly understood what these CAR T cells are. So it sounds like you're bypassing sort of the HLA, the need for T cells to process these peptides in a HLA dependent manner, and you just give them one function, which is to recognize, whatever cell type you want and to kill that cell type. And then with this new version, those CAR T cells are able to proliferate and continuing killing cells, I guess, indefinitely.
That's correct. We still hope that they eventually stop if the target is no longer there, right? Otherwise, eventually you risk the development of cancer. But that's exactly right. And you can, it's maybe hard for people to understand that limitation. But if you think about how many different HLA molecules there are, even if we had a patient population with the most common HLA class 1 allele, it probably will only capture 20 or so % of the total pool of patients. So you're really limiting the utility of your product. And now we're at a place where we can really, take something off the shelf and maybe apply it to patients with autoimmune diseases.
So how does it actually work? How do you sort of make these CAR T cells? Because, you mentioned that since you no longer have that need for specificity with the HLA that, is different on each individual. But it sounds, my understanding is you still require some of those patients' own T cells to engineer the CAR T. So can you sort of walk me through how it actually works, how you make the cells and then, put them into, somebody?
Yeah, this is a great question. And I'll first say that there are many answers to these questions. So I'll tell you what is most commonly done at the moment, and maybe then where the field might go. And I think this is an important discussion because what we're doing currently is what has worked for the last 10 years. But it's not necessarily what is feasible if we think about, the large amount of patients with autoimmune diseases that might want to be treated in the near future. So the current approach with second generation CAR T cells is one that we call autologous transfer. So the T cells are derived from the patient themselves. So you imagine you're a patient with an autoimmune disease like lupus. You would come to the hospital and have your peripheral T cells collected. So generally, this is done in a process called apheresis, where the soluble parts of your blood are separated from the cellular parts, and the cellular part fractions are collected. And then you end up with something called a leukopak, which are cell types that contain these killer cells, the T cells. And through a couple of steps, these cells in a lab environment would be isolated so that you have a clean population of T cells. And these T cells would then be in a petri dish massively expanded. There are lots of nuances to that, but essentially think of like growing up the cells for several days to a couple of weeks in a petri dish under ideal conditions. During that time is where the actual magic happens. where you now take the T cells and you integrate that new receptor. There are many different ways of doing that, but what's currently FDA approved is a process called lentiviral transduction. So think of a virus that carries this new genetic information. And the virus is used to essentially introduce that new receptor gene segment into the T cells of the patient. Once that integration happens, these cells are massively expanded. And then either they're isolated or non-isolated, but after 2 weeks, they're reinfused into the patient. And now in the patient, you have basically an engineered version of their own T cells that often still have their original specificity, but now also carry these CAR molecules on the cell surface that might target the B cell. And these will now engage with the target cell. In the case of an autoimmune disease, these would be B cells that we want to get rid of. And while they're engaging with the B cells, they would get activated and they would massively proliferate. So you actually see when you look at the blood of a patient that's just treated with a CAR T cell, that these CAR T cells are massively expanding in the blood before the population disappears largely. And that is the time where most of the killing happens. And if you follow what happens to B cells that we want to get rid of, they essentially completely disappear during that time period. So this is the autologous process. So you can already hopefully understand from the process that sounds very laborious, right? You need to bring the patient into the hospital, undergo the apheresis. The product often is shipped somewhere else. Sometimes it's engineered in the same hospital. Then there's this whole engineering and expansion, and then you bring it back into the patient. And you hope that the product has all the characteristics you want the product to have, right? That it expands, that the engineering worked. And often it works, but sometimes it can fail.
When you give the cells back to patients, do you somehow have to irradiate them or give them some sort of chemotherapy for those cells to be taken up by the body?
Yes, it's a good point that you highlight this. What we do currently is essentially mirroring what we have learned in oncology. And we're in a period where we need to learn how to do this effectively for our patients. For patients who have lymphoma, we have learned that you need to create the right environment or space in a very hand-wavy fashion to allow this new product, these engineered cells, to really thrive in the body and expand. And this process is called conditioning, or sometimes people use the term lymphodepletion. What it essentially is that a couple of days, 3 to 5 days before you give that engineered cell product, the patient would come in and the patient would be treated with cytotoxic drugs. Usually this is something called cyclophosphamide that we have used for a long time in rheumatology, and another drug called fludarabine. Both of them together essentially keep the patient's own immune system in check and create a favorable cytokine milieu with high IL-7 that allows this expansion in the body. We know this is important when you treat a patient with cancer, because if you don't do that, even though there might be some control of the cancer will come back. We do not know yet whether this is actually needed for patients with autoimmune diseases.
And just sticking to this sort of, I guess you mentioned version 2.0 of CAR T cells, I imagine that lymphodepletion has some risks, and then giving patients these T cells that become activated have some risks. Can you talk about that?
Absolutely. So it's important to break that down, because it's such a complex system with so many different things that are happening to the patient. So I like the way that you think about it. We know that whenever you put a T cell in a patient and the T cell does what it's supposed to do, which is killing and proliferate, there will be some side effects from this. And the side effects are kind of a function of how much activation of the T cell is there and how much the T cell proliferates. And I think of these as cytokine-related toxicities, because every time a T cell gets very activated, proliferates, it spews out cytokines, including interferon gamma And those cytokines activate other immune cells, including something called monocytes and macrophages, and they produce other cytokines, including IL-6. So it becomes something that is full of cytokines, and people sometimes use the term cytokine release syndrome or cytokine storm to define that state. When that happens, and it can happen with CAR T-cell therapy, patients can have various symptoms. They might have a slight fever on the lowest end of the spectrum. They might have a higher need for oxygen or lower blood pressures for a while. But especially early on, when we first started to learn how to use these therapies, people got really, really sick. Nowadays, there are good protocols in place to treat early so that we prevent progression to something that's severe. And that is typically done with drugs that we commonly use in rheumatology that target specific cytokine hubs. So there are drugs like tocilizumab that target IL-6 receptors, drugs that target IL-6 directly, like ciltuximab. There are IL-1 receptor antagonists like anakinra, and frankly, good old glucocorticoids. And depending on how severe, the side effects are, people intervene early now to abrogate that. And that has essentially allowed to still have all the benefits of the CAR T-cell treatment without having the side effects. So that's the first part. There are rarer complications called immune effector cell-associated neurotoxicity syndrome, or ICANS. You can already tell, like, oncologists like very long names. So these are essentially names that we took from oncology. And think of it as a neuropsychiatric complication of these. These could be seizures or other things. The good news is that for patients who are treated for rheumatic diseases and autoimmune diseases, these toxicities seem to be much less common, but more importantly, much less severe than we have been used to in patients with cancer. And that's probably because the target cell burden is much, much lower. So you're essentially depleting a very small amount of B cells compared to somebody with very bulky lymphoma, where all the lymph nodes are full of very refractory and resistant B cells. But the other part might be that the cells are not resistant to killing. And the end effect was that essentially in trials to date, we have seen almost no ICANS, so the neurological toxicities. And the CRS, the cytokine release syndrome, has either been absent or very, very mild. So I think that is a toxicity spectrum that we can manage pretty well. If you want me to comment on a couple of other toxicities, I'm happy to do that as well.
Yeah. How about immunosuppression?
So, that comes down to this early period where we give the conditioning therapy, the cyclophosphamide and fludarabine. As rheumatologists, we are very familiar with the drugs and what it means to our patients, right? So, like, we all have seen the patients who get cyclophosphamide get very sick from infection, because what essentially happens over the next few days is that all your immune cells are depleted, the neutrophils, the innate immune system, but also the T cells and B cells. So for a period of a week or two, there is this window where you're at high risk of opportunistic infection. And one of the reasons why patients, at least at the moment when they get conditioning therapy and in the cell product in clinical trials, are monitored in the hospital, is that you can early intervene on any cytokine-related toxicities, but also that you pick up on infections very early and treat them aggressively. And essentially all patients who are treated in trials are on prophylactic medications to prevent fungal infection, viral infection, and rare opportunistic infection.
Got it. So you mentioned initially that these therapies were very good for lymphomas and myelomas, and now we're thinking about them to treat rheumatic disease. So can you tell us a little bit about which rheumatic diseases have been chosen and what some of those studies have revealed when CAR T has been used in patients with autoimmune and rheumatic diseases?
Yeah, so the field is moving very fast. So probably by the time that that we end this call, another rheumatic disease will have been trialed. But most of the data at the moment really comes from patients with lupus, myositis, and scleroderma. When I first started to think about this field, I was really struck by a single case report, and I think it has been gotten lost a little bit in history because it was in a small journal, but it really, I think, demonstrated already the potential of these drugs. And that was a patient that was treated at MD Anderson that had very refractory antiphospholipid syndrome. And, when I say refractory antiphospholipid syndrome, this is the patient who has been on our standard of care, who was on Coumadin, and despite being on blood thinners, had recurrent thrombotic events, heart attacks. And this patient developed a diffuse large B-cell lymphoma, probably unrelated. So as CD19 CAR T cells were already standard of care at the time, the patient was treated with a CD19 CAR T cell. And not only did the lymphoma completely melt away, the bulky lymphadenopathy, but what they observed in short follow-up was that the antibodies that are characteristic of antiphospholipid syndrome completely disappeared, and that the patient had no follow-up events and eventually transitioned off Coumadin. So already early on, by coincidental treatment of a rheumatic disease, there was this feeling that there could be something really transformative. What really changed the game was now about 3 years ago, where the first patients with systemic lupus erythematosus that was refractory were treated on purpose with a CD19 CAR T cell.
Right, for their autoimmune disease rather than
for autoimmune disease.
Yeah.
And what was striking about this is maybe twofold. So the results, I think, surprised people, not because it was unexpected that it would work, but because it was so profound in the way it worked. So let's step back for a second. Lupus, right, is probably one of the most complex diseases that we see, incredibly heterogeneous. So many drugs have been trialed in this disease, and essentially all lupus trials either have like very small signals or they fail, right? They fail to meet endpoints. And for the longest time, this has held back the care of our patients because we couldn't get any drugs approved. So we're used to trying new things in lupus and essentially being humbled. So now came the first patient who had essentially exhausted most of the opportunities that we have therapeutically. So this patient had been treated with drugs like cyclophosphamide, rituximab, a monoclonal antibody that targets B cells that are CD20 positive, mycophenolate, other drugs, including high doses of steroids. So a patient that, despite our best efforts, had very significant disease. And this patient now received cyclophosphamide and fludarabine, the conditioning therapy, and then a pretty standard second-generation CAR T cell, an autologous one. So the patient's blood was taken, it was engineered to put in the CAR, and then it was reinfused into the patient.
Targeting CD19 cells?
CD19. So it's a little different than the rituximab that we have become so familiar with, right? Which failed in lupus, by the way. And what was so striking is that within, the period of observation that was very short at the time, just 4 weeks to 6 months, the antibody levels had normalized. So this patient had antibodies against double-stranded DNA, a pretty typical autoantibody that's fairly specific for lupus. They completely disappeared. The disease activity, measured as something called the SLEDAI, went from high to essentially zero. And a lot of the other markers that we think of immunologically as indicating lupus activity, right? So complement levels, they're often low when a patient flares. They normalized. So if you visualize this patient, you have a patient that is like essentially the typical patient that we see when they flare with very active disease in the hospital. The kidneys are failing, there's proteinuria, there's rashes everywhere, arthritis, complements are low, antibody levels are high, was treated one time with this combination And now, for all intents and purposes, it looks like the patient doesn't have lupus, right? Like probably
My
comes
goodness.
to your clinic and has
Wow.
no measurable disease activity. The antibodies are normalized. The complement levels are normal. So just something that is such a stark contrast to the previously lived reality, right, of treatments and trials in lupus, then it has been remarkable. So you asked about the hype, like why is the hype so big? I think the hype is so big because one, like that degree of response is unprecedented. But two, it looks like that this response can be sustained for several years potentially in some patients. And the longest treated patients are now maybe 3.5 years out. I didn't really count recently, but these patients are still in remission. And it is somewhat in potency analogous to the data we know from autologous stem cell transplantation in patients with autoimmune diseases, something we don't commonly do because it's very toxic, right? But there you achieve an immune reset. After that immune reset, we know that patients can be without disease sometimes for their life. In 50% of the patients, the disease comes back, right? But it gives you this window of maybe not having any ongoing damage to your organs. And if you think about that as if you extrapolate that, what it means in terms of, saving organs and life expectancy, I think it's remarkable and deserves the hype.
So would you say that those patients are cured of their lupus?
I'm not a fan of phrasing it that way. I think for patients, I think it's probably the closest like framework for them. Like think of the time you felt like before you had lupus. If you have a lot of damage to your organs, the damage will likely not go away, right? But like if there's no damage, think of like living at the time before you had lupus symptoms. Why don't I like the term cure? I don't like the term cure because you're achieving a selective elimination of memory B cells, and that leads is sufficient to achieve this complete disease control. But you're not modifying the patient's autoreactive T cell repertoire, at least not fundamentally touching it. You're not touching a patient's genetic risk, right? You're not changing the environment that contributes to lupus development. You're not altering the microbiome, at least we don't know it yet. So you are deleting a part of the immune system that's essential to have disease, but it's not the same as reverting to a state where, you don't have lupus at all.
And why do you figure that CAR T cell, CAR T cell therapy against, CD19, is better than antibody therapy against CD19?
Such a good question. So I need to speculate a little bit, John. So for rituximab, which is the canonical antibody that we use, monoclonal antibodies, targets CD20. So you already pointed out, right? CD20, CD19, they're different numbers. So there's probably a difference there. And that's true. CD20 is on a smaller subset of B cells. So you're not reaching a more differentiated state of B cells called plasmablasts and some plasma cells. So it is possible that just that makes up some of the difference, but I think it's unlikely. I think it's more likely that what you're seeing is a difference in depth of depletion. What do I mean by that? If we give rituximab, it makes us feel good. It makes us feel good because when you measure, the peripheral B cells, so the ones that are circulating in your bloodstream, they're completely gone, right? You can't find them anymore. But if you actually biopsied, a patient where the depletion matters the most, be it the kidney of a patient with lupus or the synovium of a patient with rheumatoid arthritis, so right at the site of the joint where you have these clusters of autoreactive B cells that drive the disease, there you don't achieve full depletion with rituximab. It's very bad at doing a good job in the actual tissues. I think the fundamental difference that we're seeing is when you engage an immune cell, when you use an immune cell therapy, like a T cell, an engineered T cell, or a T cell that's re-engaged with a bispecific antibody, what you're able to do is you leverage the natural qualities of the T cells, which are little foot soldiers. They're really good going through all the tissue niches and seeking out their targets. And all of a sudden, you're able to get rid of these enriched autoreactive cell populations that are in the tissues, and then they're gone forever, right? So if you deplete everything, the only way the cells will come back is from prior cell states. So they will not have a memory of prior infection, but also not a memory of attacking your body if you have lupus. So this is the concept of deep B cell depletion or immune reset.
So in that scenario, you would, because I imagine that these patients over time develop more B cells, but you're saying that they're coming from these progenitor stem cells that aren't trained to recognize self proteins. So when the B cells regenerate from the stem cells, they don't, recognize DNA or any of the other autoantibodies that the cells of patients with lupus have been trained to recognize.
That's correct. So what typically happens to our B cells is that they start from a very naive state. That's what we actually call them. It's a naive B cell. And they have certain very broadly reactive receptors on the cell surface that often are of an IgM subclass. When they experience for the first time and they're brought together with their antigen, the B cells get activated and they actually undergo processes that matures their specificity. So these B cells, two things happen to the B cell receptor in these B cells that get effectively activated. They accumulate small mutations in the B cell receptor in the antibody gene, and that makes them bind much stronger over time. And the other thing is they do something called class switching. So they switch from an IgM to an IgG or an IgA on a mucosal surface to have better effector functions for where they're supposed to be. And those antigen experienced cells are the ones that contain the populations that target self in patients with lupus, but also the ones that respond to COVID, for example, when you have an infection, right? So the therapies, CAR T cell therapies or other therapies that can achieve this deletion of the memory compartment essentially wipe out all these antigen experienced cells with the class switch. So the only thing that's left are the early cells that have not experienced the antigen yet, have not undergone this class switch, and the hypermutation, it's called somatic hypermutation of the B cell receptor. So these strategic mutations that make the affinity higher, and therefore these patients do not have cells left that recognize double-stranded DNA as foreign. But they also don't have cells left that recognize COVID-19 or other common bacterial infection. I'll say there's a little asterisk to this. And the little asterisk comes from the fact that CD19 is not on all B cells. There is a population of long-lived plasma cells that sit in bone marrow niches that spew out antibodies and that don't have CD19 on the cell surface. Those are not touched by these therapies. So they give some residual protection, particular to vaccine responses that we encountered in childhood. But it's not perfect. So there's certainly a trade-off. You're deleting basically the lupus memory, but you're also deleting a lot of what we have learned over the years in fighting off infections. So these patients deserve to be revaccinated and they need to be re-educated from their infection fighting perspective.
Wow. And from what you mentioned, I mean, sounds like a very time-intensive and probably costly therapy to do this CAR T cell 2.0. I think earlier you were hinting at, there may be newer strategies about how we can do this maybe better, maybe more specifically. Can you talk about, some of the work that you are currently doing and some new ways of using this types of therapies to treat autoimmune disease?
Yeah, it's such a critical point, John. I think access to these therapies is a huge problem. We know this already from the oncology population. Most of the CAR T cell therapies that have ever been given have been given in the last 2 years, right? So we're at this inflection point where more and more indications just in oncology will become reality. So we're moving from just liquid tumors to solid tumors and a wider and wider and earlier patient population. So we will have, with the current ways that we administer and develop CAR T cells, real access problems that are unsolved at the moment. You can imagine that the population of potentially eligible patients with autoimmune diseases is even bigger than the cancer population. So, it is a real world problem that deserves to be solved. So there are a couple of options. I think autologous therapies, as they're given at the moment, are probably the hardest to carry out long term. That's what we're doing. That's what's FDA approved. That's what mostly is in clinical trials. But I don't think it will be sustainable, at least not with the current technologies and methodologies. So I think what we'll see from evolution of the field in the next few years is we will see a lot of momentum in the allogeneic CAR T cell field. So that means that you're not taking a patient's own T cells, but think of going to a donor, a healthy donor, and collecting all their T cells and engineering them in bulk. But now you need to do a couple of additional things so that the cells don't injure the patient. So when you take T cells from somebody else and put them into a patient, they will react with the patient's own body. So there's the risk that on top of the autoimmune disease damage, you create damage that's called graft versus host disease. That would be detrimental. So to avoid that, you need to delete the T cell receptor on these donated T cells, and you need to do some additional modifications so they're not immediately rejected. But if you do that, and there are clinical trials now moving similar CD19 CAR T cells into clinical trials for autoimmune disease patients, you might overcome some of the current limitations that are innate to the individual apheresis and T cell engineering, and you might have a much more consistent product that's off the shelf. It's shipped basically in a small vial to the hospital, and it's thawed at the day of administration and directly administered into the patient. There are a couple of other nuances how people do it. There are iPSCs, so stem cell derived CARs, so that you have basically an engineered cell that reproduces more and more engineered cells, and these can be administered. And then there is a whole field that is trying to move CAR T cells into in vivo edited CAR T cells. So think of it using cloaking basically the DNA that encodes for the receptor into a bubble, like a lipid bubble, and injecting it now into a patient. And the hope is that over time, you can selectively target T cells that way, engineer the T cells for maybe short periods of time, and still have the needed potency to achieve that B cell reset. I think that's early, but I think those are the ways that we can overcome some of the barriers, making this therapies that are safe to be given outpatient, off the shelf, and less relying on lymphodepletion.
Amazing. I like the idea of the off the shelf, you have your cells that target CD19. You give it to, maybe you give some immunosuppression to the patient, you give them this cell therapy, and then, over the next, weeks to months, kills all, most of their patients' CD19 positive cells. And that certainly sounds easier to do and a lot less expensive. In all of these examples, we're targeting all CD19 positive cells, which, have the benefit that some of those CD19 positive cells recognize self. And as you mentioned, have the downside that you're getting rid of those cells that recognize COVID-19 or measles or any of the other, vaccine, associated conditions that that patients have either experienced or been vaccinated against. So, is there a way to just target a specific population of T cells that are just the bad ones and leave everybody else, unaffected?
Yeah, John, you definitely point out, I think, an innate problem with the approach, and my lab is particularly interested in advancing therapies and building better therapies that are antigen specific. So what you're describing, essentially going after the bad B cells while not touching the protective B cell responses, I think would be a game changer if we can do this effectively, because of the amount of cells we're talking about. So when we think about what population of all the B cells in a patient actually cause the damage, we're probably talking about 1 or 2 or 3%, right? So we're deleting 97% of cells that protect us from infection and cancer. And I would argue at the moment, in the absence of something better, that's the way to go, right? But I do think we have so many incredible new engineering tools available at the moment that there is no reason why we wouldn't be able to advance cell therapies that are precision therapies that can only get rid of the autoreactive B cells, but not touch the normal B cells that protect us. And my lab is working on a couple of approaches to do that. One that we have in preclinical development is something we call catcher T cells, CATCR. So these are chimeric autoantigen T cell receptors. So to break that down, so chimeric, right, Frankensteinian receptor, autoantigen, there's the autoantigen and the receptor, and then we integrate it into the natural T cell receptor. So what happens there is that, it's a crazy idea where you say, well, we want to target these autoreactive B cells selectively. And the autoreactive B cells, let's say they target double-stranded DNA or a protein that's the driving autoantigen in an autoimmune disease. They not only secrete that antibody, but they also have it on the cell surface. And on the cell surface, it's called the B cell receptor. So you have like this pool of disease-driving B cells that on the cell surface have a unique receptor that all recognizes this autoantigen. So what if we put the autoantigen, now genetically engineer the T cell, so we put the autoantigen into the T cell receptor itself, so that now the new T cell receptor, the catcher, can bind to the B cell receptor on the autoreactive cell selectively, cross-link the two, and then activate the T cell to kill the autoreactive B cell, but not the other B cells because they couldn't cross-link in the same way. And I think we're able to do this in preclinical models now, and I see no reason why we shouldn't try to advance these into clinical trials, because if we can, I think we'll have a future where we'll be able to achieve the same potency that we're now seeing for CD19 CAR T cells in many of our diseases, but without the risk of infection and without causing immunosuppression. So it's kind of the holy grail of rheumatology. So it's probably still a long way to get there, but at least, in the research lab, we're able to do this now.
And I guess you would need, a specific autoimmune disease that has like one cell with one autoantibody that is responsible for the manifestations of the disease. So if you have, maybe as you mentioned before, antiphospholipid syndrome, and you have the cells that are producing, I don't know, beta-2 glycoprotein antibodies, and that's the only problem, you can kill those cells and probably the patient would not have antiphospholipid syndrome anymore. But in a disease like lupus, where patients make so many autoantibodies, do you think that type of therapy would be effective as well?
Great question. So we don't know, I think, is the answer. So obviously this is immediately applicable for organ-specific autoimmune diseases where there's typically one antibody, one antigen. Lupus is the odd one out because, as you know, there are hundreds of different antigens that are being targeted. And we actually, know from some subsets that they have pathogenic potential, but we don't really have a good grasp which ones are actually driving disease, which ones are not. So that's probably the hardest disease to target with an antigen-specific approach. There are two possibilities. I like to think of our immune system and autoimmunity as a house of cards. So if you pull out the right card, the house will collapse completely. And essentially, one of the early criticisms of drugs like TNF inhibitors, which are now everywhere, right, and have transformed the care of patients with rheumatoid arthritis and other diseases, is, well, it's just one cytokine out of so many, right? How could that possibly achieve remission? But the reality is it does, right? For CD19 targeting and lupus with CAR T cells, one of the criticisms could have been, well, you have dendritic cells that are dysregulated and you have autoreactive T cells. So if you just target all B cells, how could it possibly achieve disease control and maybe even cures, right? You use that word. Well, I don't know, but it does happen, right? So now I wonder, in a disease like lupus, if you think this is lupus with double-stranded DNA antibodies, what if that is the same hub? What if you pull out that card? Will you achieve remission or not? I don't know, right? But I think we'll learn. A shameless plug, like we're working on some strategies in lupus, not exactly the antigen-specific targeting approach that we have been discussing, but a more selective precision immunotherapy. And we'll probably present this at the ACR meeting this year. So stay tuned.
Amazing. Yeah, I like it. I like that idea. And I know, I mean, it's been an incredible time. I think I get emails from companies that are doing CAR T cells to see if I want to, start up a research study with CAR T in patients with, various types of autoimmune diseases. I know that in my hospital, currently there's at least two clinical trials that are starting. One, I think, is on lupus, and the other one on vasculitis. And it's interesting to see, how many diseases, could potentially be helped with CAR T cells. But let's talk about some of the opposites. So, which rheumatic diseases do you think are not amenable to CAR T cells?
Yeah. So the ones that are giving you a half answer, right? The diseases that are amenable are the ones that are B cell mediated. So I'm not telling you which ones that are. Obviously, we have seen that lupus certainly belongs there. A subset of myositis belongs there. Probably not all forms of autoimmune muscle disease. Scleroderma, probably showed a better response than many of us expected, but certainly is not the same transformative response we have seen in patients with lupus. I expect rheumatoid arthritis to respond well. Antiphospholipid, even though trials are currently shying away from that because patients have the risk of thrombosis, and I think for no good reason. Diseases that are T-cell mediated will not be suitable for this approach. So when I think about, patients that I see in the hospital, I often think, where are they on the spectrum of B-cell mediated, T-cell mediated autoimmune disease, autoimmunity, and autoinflammation? And it kind of like helps me think about treatments that I might want to try in them. If I think about patients with psoriatic arthritis, psoriasis, ankylosing spondylitis, right? Behçet's disease. Those are diseases that I think will not be effectively treated with a CD19 or B cell targeted CAR T cell. We will need other approaches to target those effectively. And I think there are ways to do that. But just because we don't have the same head start from oncology, this will take 5 to 10 more years.
Yeah, I'm thinking about, I treat patients with autoinflammatory diseases where, at least they're not the primary driver in familial Mediterranean fever, PFAPA in children, CAPS, TRAPS, like all of those. Maybe we'd have to, think about other ways of targeting some of these, the innate, part of the innate immune system in some of these diseases.
You're absolutely right. But I think the beauty is, right, that we now have the tools to really think creatively about engineering solutions. So I think it will be a matter of time. We're at the moment using the most crude ways of, affecting potent change. but over time, there's no reason why this can't be selectively done for other diseases. So maybe we need to have another coffee discussion over autoinflammatory syndromes, John.
I love it, Max. This has been a really wonderful conversation. I think you've really clarified, what these CAR T cells are, how they're currently being used, and you hinted at ways that we could perhaps selectively target, just the autoreactive, B cell populations to treat patients with autoimmune diseases. And, I look forward definitely to speaking with you again, because I'm sure in 6 months or even a year from now, there's going to be a lot more data and, from patient data about, people receiving these treatments for their autoimmune diseases.
Yeah, I couldn't agree more. And, I know that patients might be listening to this as well. And kudos to you for sticking to the end. But I want to maybe then leave with something that I tell patients now. And I think this is such a pivotal time in rheumatology. And I think the main lesson here is a lesson of hope, right? That we're getting into an era where we can selectively engineer tailored solutions, and we will see, I think, real cures in our lifetime of rheumatic diseases. So if you're struggling with an autoimmune disease now, there's a good chance that you might not need to live till the end of your life with that disease, right? And I think that is such an important point to make to patients these days.
Amazing words of hope, Max. And thanks again for your time here and for everything that you're doing, for patients with your research and clinical work.
Thanks for having me, John. That was fun.
Wow, that was a deeply insightful conversation with Dr. Max Konig on CAR T cell therapies in rheumatology. We did a lot, including exploring the potential of these engineered cells, the processes behind their creation and administration, and the challenges and risks involved. We examined how CAR T cell therapy compares with existing treatments and discussed some of the preliminary outcomes so far. Dr. Konig provided a glimpse into ongoing studies and what the future may hold for this innovative approach. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. Until next time, keep exploring the cutting edge of rheumatology. And of course, stay healthy.